you can, probably from the lateral side, because of course we've got the lymphatics and the veins on the inside, and just try and sort of see what best you can do. Reed in his book says this is a very difficult thing to inject, and unless you inject it under radio controlled circumstances with x-rays, it's very, very hard to find it. But this is the position that you would find it in. Look for it in this position. Localize where from the lesser trochanter, okay, to where the tendon is coming down, come onto the pubic ramus, come along the bone, and that's where you would find it in here. So on the whole, you're just going to do some gentle palpation, and if you can find an area that is incredibly sensitive, that is the bursa. So once again, it's a matter of just cutting down on activity for a little while. I think this one's quite hard to treat, a psoas bursa. But I haven't seen fantastic numbers. I mean, I'm not talking about one a week or anything like that, perhaps one a year or something, if I recognize it. But I found with this palpatory thing of a sort of fairly complete palpation done at the end of all your things when you're just now into an area, because I mean we wouldn't be likely to be doing palpation all over the buttock because we've focused ourselves with all our other tests. Then this becomes meaningful if we think, right, what structures are down there, how can I put them under stress, what is their orientation, and then do it under those circumstances rather than just start poking around and thinking about something else. Then you kind of think you've been poking around there, oh, what have I done? It's like reading a book, isn't it? After 3 pages you think, geez, okay, let me go back and start again, when your brain's been wandering. Okay, let's just do that now, please. We're not going to have time to do justice, unfortunately, to some of the concepts of Janda. But we know that Janda made a number of very astute observations. And these observations were largely around the functional or the dysfunctional behavior of muscle. And as a result of the dysfunction that he was finding, or sometimes as a result of the known behavior of this muscle functionally, muscles were divided into 2 groups. There was the phasic group, and there were the postural group. And these aren't always what you would imagine in sort of traditional terms, but they were sometimes defined by our knowledge, sometimes defined by the way that they became dysfunctional. But what he found was that the characteristic of muscles that are essentially phasic, in other words, intermittently active, such as muscles like the vastus medialis obliquus, for example, that the basic dysfunctional state of these muscles was to become weak. That's what happened to them. Whereas the postural group of muscles, essentially, they shortened. And there was an antagonistic relationship, of course, between many of these muscles. Sometimes one of these muscles is the direct antagonist of a muscle within the other group. And that there was a very dysfunctional relationship between these two. So that if we had a shortened antagonist, its agonist, if it was a weakened group, there was absolutely no point in trying to strengthen this until the essential postural muscle that was its direct antagonist had been stretched somewhat. So when we're looking for dysfunctional states and weakened states, it's very important to take into the consideration the length of the antagonistic muscles. Otherwise, we're spending a lot of time doing things that's disappointing to both the patient and to ourselves. Now, what I'd like to do is to just simply list out some of these. And if any of you have been on any of the Yanda courses recently, then let's pool our knowledge on this. This is important because it's a number of years ago that I went on Yanda's course. And I remember I was supposed to be going out with him in the evening and I was incredibly ill. It just came to me. I don't usually get ill, and that was really a very disconcerting experience. So whether I was having my psoas stretched and everything, I don't know, but I had a lot of problems that night. So, phasic and postural. When we start talking about here downwards, and we look at the postural group to start with, I'll just list these, and then we'll try and find their direct antagonists, which might be weak. We'll get in the extensor muscles of the spine. We'll put in quadratus lumborum. We'll put in psoas. Put in iliacus, hamstrings, adductors, rectus femoris. Okay? If we look at the direct antagonists of these, perhaps the direct antagonist of this little group over the hip would possibly be the gluteus maximus. The direct antagonists of the adductors would be the abductors. So we're talking about gluteus minimus and medius. So therein lies a big functional problem if we've got tight things here. With hamstrings, we've got a muscle here that's sort of a little bit out of its group, but not really, because the direct antagonists of the hamstrings, I suppose in the knee itself, would be the single joint quadriceps. And probably of the quadriceps, where we see the greatest possible weakness would be in vastus medialis. I think we should put down here on the tight side the not TTA, iliotibial tract, ITT. All right? So, when we kind of look at this little plan here, it's obvious to us that there's some stretching that needs to be going on before we start doing any re-education possibly of the muscles in the posterior ilial region, which is so responsible for stability and so forth of the hip joint itself. Now, are there any other things we should put on here that should fit in properly here? Abdominals would be the direct antagonists here. And we've got certainly as far as rectus abdominis is concerned. And then I think we've got a sort of a little difference, haven't we, with perhaps some of these tight bands that we get in, say, the external abdominal oblique, which kind of comes into what Yanda talks about with this sort of lower crossed syndrome and all kinds of words that he uses for switchover of various muscles. Not switching from one function to the other, but sort of seeing layers of this is weak and that's strong and so on coming down. And I'd hope to say a little bit about that. But just for the time being, so we can keep on doing practical, this would be a good little starting point. So, what I'd like you to do for a second or two is to look at your favorite ways of having a look at the psoas, the iliacus, the hamstrings, the adductors, and rectus femoris. That'll be a kind of a good start for this stretching around the hip. Now then, before we do that, in the notes that I put out, and this is before I'd sort of thought about telling you, too much about Reed's book or pushing it. What I've done, and I got his permission to do this, that the book that he has now written came out of a number of study courses of sports medicine that he did, that I attended a number of years ago, and there was kind of like some manuals with this. And what I did was, last time I saw him, was asked if we could use some of these older manuals as an example of what his work is like, and he was kind of quite pleased for us to do that. And so this is what you've got in there with various selected conditions in the lower limb itself. And one section he's done that he's done very well in his book is to look at properties of collagen and how do we stretch and what do we do. Now, what kind of ideas have you got on this business of stretching collagen and indeed on trying to lengthen muscle? What's the kind of key stuff about it?
Low force.
Low force, long time. Yep. One, heated. The warmer it is, the better is going to be the elongation of the collagen. Don't stretch if it's cold unless there's absolutely a crying need to keep it sort of anesthetic in terms of the cold response, but otherwise don't do it. Minimal pain, yep.
Active involvement patient.
So this would mean the sort of active relaxation procedures. Okay, so we could use the, let's put it down as post-isometric relaxation or reciprocal inhibition technique, which would be good, but unfortunately with the reciprocal inhibition technique, we might be trying to activate one of these weakened agonists, so that's not very good, so we'll probably be using this much more. There was that principle that was utilized that actually Reed did some of this experimental work himself with rat's tails, which was to look at, if we've got fairly local tightness of bands, how efficient ultrasound is in terms of heating up small areas of muscle. The one that we used to use, although I don't do it now because I can't afford a shortwave diathermy for the odd times I would ever use it, was the inductothermy cable, was an extremely good way of doing this. But one of the important observations that has been made is that once we've stretched a muscle, that it's very useful to keep it at that elongated position and rapidly cool it. So that while we're stretched, let's say with a tennis elbow or something, if you've gone through, let's have you doing some movements here, let's have you warm it up in the water, now let's go for the stretching, now let's go for the Kerwin-Standish plan of what I suppose is plyometrics, then let's go back to the stretching. Now, sit there, read your paper, put an ice pack on, and hold that stretch now. And it seems that the collagen bonding is much more reluctant to reform in its original positions if we cool this down. And I think there's a lot of work that, we require to do on this particular thing. But when we're stretching, this low force is okay. The long time is not so okay. Certainly in our system, because we've got to kind of move patients through the system fairly rapidly. So this requires good teaching, I suppose. And when we've seen how difficult it is to totally stabilize so something else doesn't give, this really takes quite a bit of teaching. So, if we could look at these little things as examples, the psoas, the iliacus, the hamstrings, the adductors, and the iliotibial tract, and the rectus femoris. We can do all that group. It's not going to take you all that long just to sort of go over your things, and let's have a look and see what is the best positions for doing these in. And what are the possibilities for doing them in, and are there any advantage for doing them other than, one way or the other. Can we do that? Before lunch. We've got to finish this before lunch. We may not even be able to have lunch today. Okay, let's go. We place the lumbar spine in to give the very finest stabilization if we wanted to stretch the psoas? What is the total, absolute, perfect position for the lumbar spine if we want to stabilize it maximally as we're going to stretch the psoas?
Well, flexion, opposite side bending, and rotation. Just flexion, and then if you're stretching the left psoas, have it in right rotation, right side bending. So you can't left side bend or left rotate.
No.
Isn't it going to want to tend to left rotate? If you stretch the left psoas,
So you put it in left rotation.
you put it in right rotation, so it can't rotate left.
No, it's going to pull this forward into right rotation. So you're going to put it into left rotation and lock it in left rotation. So yeah, okay. So the spinous processes the spinous processes have gone posteriorly, and you hold them there. So you normally think, I'll side bend the opposite way to kind of stretch it a bit, but in actual fact, you side bend towards the side you're stretching. In flexion, because we're in flexion, which rotates you to the same side, which takes these spinous processes or the transverse processes posteriorly on that side and holds them there because we keep the side bend. So this is a sort of looking for this absolute stabilization. Now, all of you, we're doing these perfectly right. I don't know about the rotation business of the psoas. We all had this little thing in our heads when I was at school. Is it a medial or is it a lateral rotator? All the modern thinkers thought it was a medial rotator because we were all following Grant and his thesis in his method of anatomy. Why was this? The muscles coming to here, of course, to the trochanter, the lesser trochanter, but then we've got what he used to argue was that we've got the length of the femoral neck. So when you sort of pull this, it doesn't sort of go like this. When you pull anything at the back, it pulls forward, but the whole of this swings forward. So we were already in exams to kind of give them this little spiel about the controversy. Well, of course, what happened was that Basmajian looks at the psoas and finds it's not really very active in rotation either way, so it's not a major problem. I know that Olaf, when he does his stretching, tends to, when he goes into full stretching, to go into a medial rotated position, so presumably he feels that it's a lateral rotator. The only other group was the one, Bruce, just come here a second. We can do so many variations of these things. With Olaf, with his 30-odd pages, of taking muscles, say like the adductor group, for example, where we are trying to think about coming into a variety of sort of positions so that we're up here and out here and stretching into medial rotation for the sort of posterior ones. And we can do a whole variety of these kind of combinations. It's really just a matter of looking up, isn't it, what they do, and then trying to sort of do a comprehensive group. Can you lay on your side a second to face away from me? For example, the sartorius, I was talking with Kent here, the sartorius which does this, one of the best ways of getting this would be to sort of come into this position and sort of stretch up in medial rotation and extension and coming back here, and I can stabilize the hip and come pulling up into this position. So there are a whole group of things that we can do around here, and it's just a matter of following, I think, our little rule here about gentle, persistent, wherever it is, gentle and persistent, having heated the thing up, perhaps trying to teach a reasonable kind of exercise for some of these. And some of the positions that we're using aren't really possible for a patient to replicate in any way. For those of you that didn't look at the iliotibial tract or haven't done, got the knowledge of Evian, I think that the one where he is coming back into this position where he's medially rotating this, he's fixing the pelvis and he's coming up into this position is by far and away the most superior technique done for the iliotibial tract. And of course then to do it in this position like this now as a home exercise, foot turned round, other leg in, and coming out to the side and pushing out like this is a very, very good replication of this particular procedure. So I think that, you know, there's some good techniques that we should be doing, and there's some simple things, you know, that people do wrong, and you see in the various stretching books wrong, such as the stretch for the rectus, for example. I think this should always be done with the hand on the opposite side, so you keep it in adduction rather than, you know, just kind of stretching back like this. And we've got to make sure that the patient doesn't allow this to come forward, so they've got to keep fairly up straight here so they don't bend forwards, but this keeps it in adduction and stretches it much more completely than if we do just lifting the leg up, as most of the books say. So here's a sort of an interesting group of things that we can think about around the hip. Now, we have two things to do, and we'll do them after lunch. One is to do the little kind of loose body procedure, which is not really a manipulation in the strict sense of the word, but in this joint it's one of the few you do, and we'll also do a little distractive manipulation, which is pretty well almost the same as we did yesterday for the procedure of upslip. I mean, we're just going to do it down the leg, pick up the thing and just do a little distractive pull. But it'll get us used to doing quick little things to joints. But this is not a joint where very much manipulation is very appropriate because of the size, because of its total range of movement, because of the big muscles around, because of its basic integrity. And it doesn't suffer from displacements as some of these other ones round the foot does. So we'll start with that straight after lunch, then we're going to go on to the foot. Okay? So we will proceed from there. So we'll have lunch and we'll start again just after 1:45. Because the other important real thing, and I perhaps should get Chris to give his evangelical talk, his Billy Graham talk on this, is in terms of the importance of you people with the academy coming on and this window that people can take examinations to start with before the residency requirements start. But in actual fact, the residency requirements are going to be a very important thing, as they should be for any training in actual fact. And so this is something that I think you know, will require commitments on part of a lot of people to sort of have people in residency trainings. And you know, with Earl sort of not being totally able to sort of give the time I know that he would like, you know, and the other instructors that are my level kind of getting older and tiring, then this is for you to take up this ball and run with it, really. And I think that's really important that you know that and how important you are. So let's kind of make sure that if you're going to teach this one technique of manipulation, you'll be able to do it right. Okay. With a loose body, the kind of history with this is that it's very unsatisfactory. Patients have twinges which then seem to disappear, sometimes with certain things that they can do, and then they're all right again. And sometimes the twinges occur fairly frequently, and sometimes there's a long period between each. And when we look at some of these joints where they're fairly big capsules and fairly big internal structures, you can imagine that a small cartilaginous fragment in the hip joint or in the knee joint could get lost for a long time in the recesses before it gets driven in between the joint surfaces again and causes its twinging. And Cyriax was one of the ones that said these people, we should try and eliminate this thing. So what do we do with this? We look at a pattern where the twinge perhaps is worse. And with Chris here, we might have to do some of this in standing and just have a look at some of the positions that he can put his hip in and move it a little bit. And what we're really trying to find is a rotational pattern that causes the twinge, because the flexion extension is generally speaking the same for everybody. But if we'd got a problem, particularly into the major weight bearing, which is usually, of course, extension, we're going to start moving from flexion and gradually work into extension. And if there is a rotation that causes the problem, we'll try and rotate away from that to start with. Hopefully that you kind of just move this fragment to some part of the joint where it doesn't hurt. And of course, one of the fundamentals of Cyriax's whole concept was that you gave traction, which seems reasonable in this case, to try and separate the joint surfaces as you move them. Now, he used to start, and he used to use one of those really low tables that he was very fond of, where he could get right over patients to do his various maneuvers, and his girls used to, as he called them, used to sort of pull on the end at both ends, pulling hard, while Dr. Cyriax used to do his various procedures. So he would work this on one of these low tables because he would stand on the table and start his maneuver in standing, and then he would step off the end onto the floor, continuing with his traction and his mobility. So this is a little high to do this with. But let's say with Chris that he had some problems with coming into extension and perhaps this lateral rotation. When we tested it, he didn't like this, so he was sort of holding back here. What we would do under these circumstances is to start fairly high in this position, and because of the size of the table, I'm going to have to come down a little bit to this point here, and I would put traction on this joint to start with, and then what I'm going to do is to maintain this traction. So this is not really a manipulation in the strict sense of the word, but it's a distractive maneuver, and I would take it into a medial rotation position, moving like this and coming down into the extension position, going away from the painful rotation. Then I would ask him if he could weight bear again. And perhaps before I did this, I might try a couple of these of just pulling and just start a little movement and come down into the range like this, pulling and giving rotation at the same time. Then, having gone through the painless range and say not really altered the thing, I would now very softly try and go through this external rotation pattern, put a bit of traction on, just gradually work this, so I don't want to cause major twinging for Chris, and then as I come down, gradually increase the movement, the trajectory that I'm doing this technique over. So fundamentally, if I could start a little bit higher up because of the height of the thing, that's very difficult, and then come down and work it from about this range right the way down. Now, it is possible, can you go onto your stomach, Chris, to come into a position here, because of course I could come over the edge of the bed and pull down there, but I could come into this position also and have a look at this medial rotation, lateral rotation in this position, put some traction on, and go a little bit further up. You find, of course, coming upwards, it's much more difficult than doing this thing as you move down towards the ground. So this is why Cyriax did this on these low tables, and he could come right the way up, and generally it did not go past that kind of neutral position. But if you want to go past the neutral position and into extension, there's this alternative, or can you go on your back, Chris?
What's the criteria again for going into extension? If you didn't get it?
If it still was there in extension, to try and take it a little bit beyond that, and just come over the edge of it, Chris, if you can.
So you'd know that by having it standing again?
Just stand and just test it again. And I could come down a little bit more like that. Okay? So this is one of the first things that we shall do, which is to pull and then to try and get pain-free rotation to start with, going through the total flexion to extension trajectory, and then start into the painful, just easy, with your traction. As you feel you're not aggravating anything, then